Good evening. I will be taking the topic basics of ophthalmic ultrasound. The indications for ocular ultrasound are, I think we have a problem with the display. Ophthalmic ultrasound is done either in opaque media or clear media. In case of opaque media, it's usually diagnostic, whereas in clear media, you sometimes want to quantitate your findings. And you can do this either transocular. Here you have the probe over the eye, and the transocular scans help you to study the eye as a whole, the posterior segment and the posterior orbit. If you bypass the globe by keeping your probe away from it, you can study the anterior orbit either superior or inferiorly. Here you are bypassing the globe. There are two basic principles on which ophthalmic ultrasound is based. The most important is the piezoelectric phenomenon, whereby if you stimulate a transducer with an electric pulse, then this transducer gets deformed. It emits an ultrasound pulse, which is then passed to the eye, and depending on the various interfaces, you get returning echoes, which are converted into a one-dimensional display, or an A-scan, or a grayscale two-dimensional display, or a bscan. And the second most important principle which helps us to interpret the ultrasound is acoustic impedance mismatch, which is basically a difference in the acoustic impedance between different structures in the eye. And once we understand this, the ultrasound, we need to assess the patient in real time. We need to interpret the grayscale. And with these two, we finally convert our 2D black and white image into a three-dimensional interpretation, which helps us to understand the condition and manage the patient better. Other terms which we need to know are decibels. You see sometimes on the top of your screen a small sign saying dB. Basically, it's the measurement of sound intensity, also referred to as the gain, and this is the intensity of the sound that is used on the transducer to apply on the eye. And the second term is the hertz, the frequency of the transducer. Typical ultrasound systems from the eye range from 10 megahertz to 80 megahertz. Conventional bscan ultrasound for the posterior segment is 10 to 20, whereas 35 to 80 is ultrasound by microscopy. And higher the frequency, obviously higher the resolution, but this is at a cost of penetration. This is an example of what we do in a patient with fresh vitreous hemorrhage. If you see here, you have only 40 decibels of ultrasound energy being used. The vitreous cavity looks absolutely clear. As you slowly increase the gain, you start seeing more and more echoes. So in a patient with a fresh vitreous hemorrhage, you're likely to want to increase the gain to see something more. As opposed to this patient with trauma, vitreous hemorrhage, and multiple membranes of varying echogenicity, here you reduce the gain, and now you see there is one structure which still stands out, and this is an intraocular foreign body. So you manipulate the gain, you manipulate the decibels to see more or to see less, depending on individual situations. Now what can you do? This is a conventional 10 megahertz ultrasound probe that we use. Here you see foreign bodies are seen well. You see a good view of the posterior segment, but you can't really see much in the anterior segment. So what can you do if you don't have a better machine? You just use a standoff, put some liquid over the closed eyelids or over the cornea, use a coupling medium, place your transducer much more in front, and you see there is a foreign body in the lens. Again, the picture is not that great. So what can you do? You can use a much higher frequency probe like the ultrasound biomicroscope, and this is able to pick out a tiny little foreign body in the posterior lens matter. But if you look at this, here you see the posterior globe wall. As you use the standoff, this disappears, and at high frequency, this is the best you can see. Now coming to acoustic impedance mismatch, this is the one basic requirement for the image on ultrasound. This is a normal vitreous. It is absolutely echolucent because the vitreous is clear, There is no hindrance to the sound waves as they pass to the vitreous. They pass directly to the posterior glow ball, so you get no echoes inside. This is normal. This is also normal. This is the orbital fat. But what do you have in the orbital fat? You have septae, you have vessels, you have muscles. There are enough interfaces where the sound is reflected at different points in time. So you get what is called a heterogeneous or high reflective or a white structure. Both these are normal. Basically, the pictures basically belongs because of the structure of the contents. And what happens when the sound wave passes through? It can either get reflected, it can get attenuated, or it can get scattered, depending on this acoustic impedance mismatch. This is a classic example of attenuation, this mushroom-shaped choroidal melanoma. Notice on the gray scale, the white becomes slowly gray and then it becomes black. What does this mean? This means the structure is homogeneous. The sound is continually being absorbed by the tissue as it passes through, so there is relatively less sound reaching the back. This is a phenomenon of attenuation, which is very typical of a choroidal melanoma. You say the same thing on the A scan here. You see the spikes continuously reducing because the sound is getting absorbed as we move posteriorly. In contrast, you have this patient of retinoblastoma, which is a highly refractive tumor, where you have multiple tissue spaces, you have calcification. So you see that kind of A scan spikes that you see the grayscale, because there's so many interfaces, tissue sound is getting reflected back and forth. You get this heterogeneous appearance and minimal sound attenuation. This is just an example, probably, if someone would like to interact on this. This is a child who had a post-traumatic choroidal detachment. If you look here, you see the large mounds of suprachoroidal hemorrhage. You see varying echogenicity suggestive of blood. You look at this picture here, and you see this little globular lesion which looks a little bit out of place. And you see here, this is a homogeneous lesion. And you see these structures here. You see how the sound gets attenuated here, but the sound keeps getting reflected back in the other structures. And this is the MRI of the patient. It's an 8-year-old, and what's your diagnosis? Anyone? This boy had an amelanotic melanoma of the choroid. So surprises can always come. If you see something like a choroidal detachment, don't always assume it's only a choroidal detachment. Look further. You see this. This is what raised the suspicion. Suddenly a homogeneous structure within the heterogeneous lesion, indicating that this was bleeding from a tumor. Now what is shadowing? Shadowing or reflection. You have structures like bone, which can be within the choroid, as in a choroidal osteoma, or as in here you have a displaced orbital bone from an orbital fracture. You see here all the sound is getting reflective back. Nothing is passing beyond it. This is the phenomenon called shadowing, and it's typically seen in choroidal osteoma or bone. This is a patient who had had a transpupillary thermotherapy for choroidal melanoma and was being on regular follow-up. You look at this ultrasound picture and you see the scar, which is highly reflective, causing what we think is some amount of orbital shadowing. But what happens when you increase your ultrasound penetration deeper? You see that this is not actually shadowing, this is actually another orbital mass. So don't always take things for granted. Look a little further, it's actually not shadowing, it's an orbital mass. This is the comparison of the opposite orbit. You see the normal heterogeneous structures in the orbit, you see this homogeneous orbital mass. This was actually an orbital extension of a choroidal melanoma. So if you see something like shadowing in the orbit, increase your ultrasound penetration, you'll be surprised what more you can find. Reverberation is another important phenomenon. A lot of us do ultrasounds to detect foreign bodies. And the typical finding of the comet tail artifact, as you see here, you have a very high reflective echo trailing towards the right side of the screen. Why does this happen? This happens because sound moves back and forth between the surfaces of these foreign bodies. Each time the sound wave loses some more energy, so you get this little trail of echoes. So this is a typical comet tail artifact seen in a patient with a small foreign body. Now that we have an idea of how reflectivity looks like, we need to evaluate the patient in real time, and that's a benefit all of us have as ophthalmologists. We see the patient, we do the ultrasound, and we know exactly what we're looking for. This is what you need to look for: the reflectivity, the mobility, the attachments of the membranes. Finally, convert your 2D image into 3D interpretation. If you look at this ultrasound here, you see these thin cobweb-like row reflective membranes moving around. This is a patient with vitreous inflammation in endophthalmitis. And if you look here there are two membranes. There is one which is a variable reflectivity, sometimes high, sometimes low. It moves much more than the second membrane. The second membrane is higher reflective. You look here, it's higher reflective attached to the optic disc. And this is a patient with a vitreous hemorrhage and a retinal detachment. So the vitreous membrane is lower reflective, moves much more than the retinal detachment, which is high reflective attached to the optic disc. This will probably see better. You have three membranes here. You have the vitreous, which is low reflective, very mobile. You have the retina, which is high reflective, attached to the disc, relatively less mobile. And you see this thick membrane here, which doesn't move at all. It's very high reflective, and that's the choroid. So you see a difference in reflectivity, you see a difference in mobility, and this is what tells you what structure you're exactly looking at. Coming to the attachments, here you see the posterior hyaloid attached to the optic disc. And you see all the echoes are behind the posterior hyaloid. This is low reflective subhyaloid blood, and the posterior hyaloid in this case does not move so freely. And this is a patient with a fresh vitreous hemorrhage. It looks fairly innocuous until you see this in the periphery. And you see these echoes seem to be attaching to this little flap that's attached to the posterior globe wall. This is a horseshoe tear. So when you see a patient with vitreous hemorrhage, you don't always look only at the optic disc. Especially if the patient is not diabetic, not hypertensive, always look in the periphery, and chances are you'll be lucky enough to spot a retinal break. This is an example how we can interpret a 2D image into 3D reality. We have a 30-year-old male with a history of sudden drop in vision. He had vitreous hemorrhage in the right eye and history of laser barrage in the left, which should give you a little clue as to what was the problem. Look at this undulating membrane that's attached to the disc. It almost looks like a serpent doing a dance if you look at this here. This is typical of a giant retinal tear. Okay? And this patient underwent surgery. And you see the blood being cleared. And this is what was the picture, indicating that we were right in our diagnosis. So any snake-like movements of membranes, high reflective attached to the disc, always think of a giant retinal tear. And it's important to look for associated findings. Things may not always be what they seem. And this child who presented with history of decreased vision in the right eye of about 6 months duration was advised RD surgery. No specific history except some vague history of trauma in the right eye. We did an ultrasound to characterize this little mass lesion above the optic disc. And you see that here within the high reflective echoes, you see two spots which are very highly reflective. And like we use the principle of reducing the gain, and when you reduce the gain, you find that this structure remains. Remember, the child is 10 years old. And basically this was a foreign body granuloma, and children are usually frightened to say they got hurt. So when you see something, always look for something more. And when I said the child was 10 years old, we've ruled out retinoblastoma, which can also look like this. So what can we do to improve anterior segment visualization? Whatever we've seen so far has been in the back part of the eye. Like I said, we can do a standoff, or we can do an ultrasound biomicroscopy. In the next few minutes, I'm going to tell you about that. Ultrasound biomicroscopy basically utilizes a high-frequency transducer, which gives you very good imaging of the anterior segment at near microscopic resolution, and you get a good idea of relationships between various structures surrounding the posterior chamber. To compare ultrasound and UBM, the frequency is higher in UBM, the resolution is better, but the penetration is only about 5 millimeters, which means it can help us to study only the anterior segment well. It's probably most useful in glaucoma. Now we know angle closure glaucoma can occur due to various causes. Here you see a patient with a very anteriorly displaced lens. You have the lens causing a secondary angle closure. Here you see the peripheral anterior synechia causing an iris Bombay configuration and iris angle closure, whereas central anterior chamber depth is normal as opposed to this one. And if you look at these two images, this is probably the most important area where you would do a UBM for a glaucoma patient, especially after a failed peripheral iridectomy. If you look at this peripheral roll of iris, and you see these ciliary processes here, they are large, they are bulky, they seem to be pushing up the iris here. This is characteristic of a plateau iris configuration. And sometimes you can get the pseudo-plateau iris configuration in patients with iris ciliary body cysts. So sometimes you have these cysts all around, which gives you the pseudo-plateau iris configuration. So probably these are two of the most important conditions where you'd want to do a UBM in glaucoma. And post-glaucoma filtering surgery, you can see varying pictures. This is a patient post-deep sclerectomy. You see the stoma, the stoma is patent, as well as you have a little filtering bleb. This is the area of the deep sclerectomy. Here you have a patient with a nice filtering bleb and a shallow anterior chamber. The bleb is functional, indicating it's probably overfiltering. In addition, you have supraciliary fluid. This is indicating an overfiltering bleb. In contrast, here you see there is no bleb at all, or just this little cyst. Anterior chamber is flat. You can't see the ciliary processes at all. This is a patient with malignant glaucoma. A similar patient here where you see an encysted bleb, but you see that the trab is not functioning well. There is no patency of the stoma. So knowing all these structures, one can very often identify why the patient has a particular postoperative complication. And malignant glaucoma, this was a patient with malignant glaucoma where there was no supraciliary effusion, indicating the need for surgery to reverse the block. In contrast, this patient had a similar picture. Ciliary processes are rotated anteriorly, but here you have fluid in the supraciliary space. This indicates that the patient is likely to respond to medical line of management, and here you see the reversal after medical line of management with cycloplegics. The anterior chamber is deepened, the ciliary processes have moved back, and there's no fluid in the suprachoroidal space. Diamox and topiramate. Topiramate is a very commonly used anti-migraine drug, and this is a young girl who presented with bilateral angle closure glaucoma following the use of one tablet of topiramate. It's known to cause an idiosyncratic reaction. You see again this malignant glaucoma-like picture, but here you have fluid in the suprachoroidal space, bilateral uveal effusion, and this is the reversal after stopping the medication. Now with the new 35 megahertz probes, we get a fairly good view of the posterior capsule, the posterior chamber, which was not seen with the older 50 megahertz probe. Here you see this in the bag IOL, which is slightly decentered. So sometimes this was just for academic interest, I thought I'll bring it. Not really necessary to do a UBM, but it can show you horizontal displacements. Here you have a little messed up surgery with a badly constructed wound, and you have the IOL haptic, you have a cyst, an implantation cyst, and basically an inflamed eye with a badly done cataract surgery. And this is a patient with a flat anterior chamber. You have the IOL here. You have a very deep posterior chamber. And this is a patient who I had been following for many years. Patient had cataract surgery, ECC IOL in 1994. He had peripheral lattices and retinal holes for which repeated treatments were done. He had a YAG capsulotomy, progressive increase of myopic refraction each time he came. Subsequently diagnosed to have raised IOP, open angles and a convex iris, and IOP was controlled with medication. And he saw us again in 2003 when he said that every time the local doctor dilated him, the pupil would get, IOL would get captured. So the local doctor was scared to dilate, so he used to come to us every time. And each time we saw this happening. You dilate, both eyes would have optic capture, then we make him lie flat, put pilocarpine, see the retina, and do that. This happened again and again. Finally, we decided to do a UBM. And what did we see? The IOL was placed so far anteriorly. You look at the sulcus fixated IOL. If you remember the pictures I showed you earlier, both eyes, the IOL was placed so far anteriorly that even one drop of dilation was causing the iris to slip off the optic edge. In blunt trauma, you can pick up cases like cyclodialysis clefts where you have a good communication between the anterior chamber, suprachoroidal space. You see the alteration of the lens contour because of zonular damage. Sometimes clefts may close, so they're difficult to pick on gonioscopy, and UBM can pick up these little gaps. In penetrating trauma, you can see damage to the anterior capsule, which you could anyway see on slit lamp, but what you would probably want to know is this. Is the rupture of the posterior capsule, how much of lens matter is prolapsing out, how safely can I do my surgery? I showed you this picture of small foreign body within the lens, and foreign bodies in the pars plana region, which are notoriously difficult to find with any other method of examination, can be found easily on UBM. Again, when you want to plan surgery for complicated cataract in eyes with intermediate uveitis and pupils like this, the presence of these mass lesions over the pars plana region indicates active inflammation and definitely not an indication for elective surgery. Whereas in chronic uveitis, you can get these membranes which pull on the ciliary processes, or sometimes ciliary body atrophy, which causes persistent hypotony. In recalcitrant uveitis, you may see, as in this condition, patient had injury with caterpillar hairs. You have the cilia here, you have cilia in the ciliary body region, you have cilia on the pars plana. This patient was taken up for pars plana surgery. And I'm sorry I don't have the video, but here this arrow shows the cilia that we could see embedded in the pars plana membranes. Finally, UBM of the sclerotomy sites. The sclerotomy is notorious for causing postoperative vitreous hemorrhage, and studying the sclerotomies with UBM can help us sometimes tell what was the cause for vitreous hemorrhage in a diabetic. This is a nicely healed sclerotomy. This is a poorly healed sclerotomy responsible for persistent hypotony, and you see the schemosis here. This is a badly done sclerotomy where you have vitreous still stuck in the wound. And this is what we're really looking for, fibrovascular proliferation growing down from the sclerotomy site along the anterior hyaloid, which causes vitreous hemorrhage. A word on surface tumors or OSSN. This is a superficially located tumor with no involvement of deeper structures. However, if you look at this mass lesion on the surface, you see it's invaded the angle, it's invaded the ciliary body region, indicating that it's much more aggressive. And in small iris ciliary body tumors, you can identify exactly how much area is involved. This tumor involves only the ciliary body. This is a small tumor, but it's invaded at angle, making the prognosis more guarded. And this is a more aggressive tumor, which involves the angle as well as the ciliary body region and other superficial structures. A final word, someone may ask, why not ASOCT? ASOCT is fine for structures above the iris. There's a lot of shadowing which occurs behind, so anything involving the ciliary body region, ASOCT is not the greatest idea. Of course, its basic advantage, it's non-contact, so for post-operative cases, it's definitely better. So with this, I'll end my talk. I acknowledge my fellows from both Chennai and Calcutta who got the videos for me and our optometrists who gave me the UBM pictures. Thank you.